Hello, I'm Jonathan Perkins, and aside from being a hospitalist, I'm also the Chief Medical Information Officer for the DeKalb operating units. And as such, I'd like to talk about preventing medication errors. Oops. So a more appropriate way to define medication error is as an adverse drug event, or an ADE. Potential ADE are errors that never affect the patient. For example, an incorrect medication dose is ordered by a provider but caught by the pharmacist. Next is preventable ADE. These make up the largest proportion of ADEs. They are, as the name implies, ADEs that cause harm but could have been prevented. For example, a patient receives an incorrect dose of heparin and their PTT or anti-10A levels become out of range. A non-preventable ADE is one that could not be prevented. For example, a patient who has an allergic reaction to a medication that they have previously taken before without a problem. Ameliorable ADE are non-preventable ADE whose effect could have been mitigated by appropriate action. So if the allergic reaction was unrecognized and the patient continued to receive that medication for 2 days. ADEs have a major impact on healthcare, accounting for over 700,000 ER visits and over 100,000 hospitalizations per year in the US. Patients have a 5.5% risk of ADE while hospitalized, with the risk increasing by 0.5% with each midnight in the hospital. This risk is second only to infection and a patient's daily risk for adverse events. ADE risk does not end when the patient leaves the hospital, however. Medication discrepancies on discharge medication reconciliation are very common. A large number of studies have looked at this over the last 20 years, and rates range from 20 to 80% of patients with at least one medication discrepancy on their discharge medication reconciliation. Risk factors for ADEs can be drug-specific, like high-risk medications, physician-specific, like polypharmacy, and patient-specific, like low health literacy. Some of the highest risk medications are antithrombotics, anticoagulants, insulin, anesthetic agents, and of course, opioids. The Institute for Safe Medication Practices maintains an updated list of the most high-risk medications. Other lists to look at would be Beer's criteria. However, this has mostly been replaced by STOP criteria, as well as look-alike, sound-alike lists. There's no standard definition of polypharmacy. But the most appropriate way to think about it is medications that are not indicated, not effective, or constitute a therapeutic duplication. Polypharmacy is the largest risk factor for ADEs. The below cited study showed an 88% increased risk of ADEs in patients who are categorized as having polypharmacy. Low health literacy and low numeracy are major issues in the risk for ADEs. Studies have shown that only about 12% of Americans have a proficient level of health literacy, and this is not a static property either. Health literacy can be affected on a daily basis by a patient's mental, emotional, and health state, as well as with the complexity of the health information provided. There are some common strategies for decreasing ADEs, and they can be categorized into 4 groups. Prescribing. Providers should avoid unnecessary medications by using conservative prescribing principles, such as reducing the number of duplicate pain medications ordered. Computerized provider order entry and clinical decision support systems should be used in all phases of patient care, and medication reconciliation should be done at all transitions. Transcribing. Except during an EMR downtime, providers should never handwrite orders for medications, especially prescriptions for home medications, due to the risk of transcription errors when these orders are entered into the EMR or pharmacy system. Electronic submission of prescriptions is the gold standard. Dispensing. The dispensing process should be overseen by clinical pharmacists. Capitalizing key letters in look-alike, sound-alike medication names should be done for all printed medication labels. Use of automated dispensing cabinets also help to prevent ADE due to dispensing errors. Administration. First and foremost, adhering to the 5 rights, which are the right medication at the right dose via the right route at the right time for the right patient. Also using barcode medication administration and smart infusion pumps while trying to minimize nursing interruptions, and finally providing patients with an appropriate medication education. Individual strategies can reduce ADEs, but they are much more robust when used as a system. It is also imperative to analyze all medication errors for system flaws so that they can be corrected. So what can you do as a hospitalist to prevent ADEs? Be vigilant, identify opportunities, and speak up. Be vigilant. I know everyone is perfect, but always pay extra attention to dose units, and route when ordering medications. These are the most common fields where errors happen. Double check before hitting submit. Maybe you inadvertently pressed another key and changed 1 milligram of Ativan to 10 milligrams. Here's a case to illustrate this issue. An 83-year-old female with a history of dementia and hypertension had been in the hospital for an episode of chest pain. She was being discharged to her nursing home after a negative workup. Her discharge medication reconciliation began a cascade of medical errors. The provider was prescribing amlodipine 10 milligram tablets. They did not pay attention to the dosage units, and inadvertently prescribed 10 milligrams tablets daily. This prescription was signed, printed, and sent with her to her nursing home. The patient did not receive this dose at her facility, but she was sent back to the hospital the following day because of her current chest pain. This erroneous order had become a home medication in the EMR. It was continued by the admitting physician. 6 medical errors by 4 different people later, and the patient swallowed 10 milligram tablets of amlodipine and passed away 2 days later. We need to identify opportunities like this for errors. No other group of physicians uses the EMR as much as hospitalists. Remember that we have extensive clinical decision support built into the EMR, including allergy alerts, therapeutic duplication, and dose range checking, but these systems are designed and configured by humans. Therefore, errors can happen. This is how the previous example happened. A poorly designed workflow contributed to this ADE. The top image is an inpatient order. The bottom one is a prescription order written in the same EMR. Both are for 81 milligrams of aspirin, but the dose units are different. Someone less familiar with the EMR may end up ordering 81 tablets of aspirin 81 milligrams daily, which is exactly what happened in this case. If you identify a problem in the EMR with orders or with the clinical decision support tools, let someone know. Too often as a CMIO, I find out that providers have been using a workaround for months because the correct pathway wasn't working. Letting someone know would have led to correction of the problem in a matter of hours and reduced the risk for ADEs. Your vigilance can be the key to prevent the next patient from harm due to an adverse drug event. Thank you.